Thank you so much for joining us tonight as we dive into a discussion about the elephant in the room when it comes to talking about healthcare in Canada, privatization. What does it even mean? And more importantly, how does it impact patients' timely access to the care they need? Before we get started, I would first like to acknowledge that while we are meeting virtually this evening, the CDM office and the home from which I am calling in today are both located in Toronto on the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. Toronto is within the lands protected by the Dish with One Spoon Wampum Agreement. The dish represents the land that is to be shared peacefully, and the spoon represents the individuals living on and using the resources of the land in a spirit of mutual cooperation. This agreement captures our responsibility not only to the land, but to one another as well, which is certainly relevant when we talk about the future of public healthcare and ensuring equitable access to care for everyone. As you are all joining us from across the country, I encourage you to consider the traditional territories upon which you live and work. We must also recognize and underscore the significant and unjust health disparities that Indigenous people continue to face today due to systemic racism and the ongoing effects of colonialism. At CDM, we are committed to working to reduce these inequities as part of our work to advocate for better Medicare. For anyone who is new to Canadian Doctors for Medicare, we are a nationwide evidence-based and nonpartisan organization dedicated to preserving and strengthening Canada's publicly funded healthcare system. We advocate for innovations that are evidence-based and improve access, quality, equity, and sustainability. As you'll hear tonight, at Canadian Doctors for Medicare, we want to talk about both how healthcare is financed and also where that care is delivered. And it is now my pleasure to introduce you to Dr. Danyaal Raza, who will be moderating the first portion of the evening. In addition to being a board member and past chair of Canadian Doctors for Medicare, Dr. Raza is a family physician with Unity Health Toronto's St. Michael's Hospital and an assistant professor with the University of Toronto's Department of Family and Community Medicine. He was a founding physician lead of Unity Health Sumac Creek Health Centre in Toronto's Regent Park. Danyaal, over to you.
Thank you, Katie, and welcome everyone. Thanks for joining us tonight. I want to start with a very brief story from my practice. It happened not that long ago, just last fall, when an elderly and socially isolated patient in my practice began experiencing unexplained weight loss and developed new anemia or low iron. Now, those of you who are clinicians who have joined us tonight, you probably have alarm bells going off in your head, just like I did, because of course, these can sometimes be the harbinger for a cancer. So I urgently started a red flag workup. I ordered the right diagnostic imaging. I made the proper consults, and we waited. My patient and I waited. Eventually, we got the investigations and the results we needed, and we were thankfully able to start on the right management plan. But I think we waited longer than we needed to. And during that wait, I was putting in calls to the specialists I work with. I was regularly checking in for updates, and I was making sure that my patient was coping in the meantime. Now, I share this because I think odds are, whether you're a healthcare worker in the system, whether you're being cared for, or you have a loved one receiving care, this may not be an entirely unfamiliar story. We are in we're not post-pandemic, but we're in the recovery phase. That's, I think, for sure. And COVID has thrust our system into a deep crisis, and we are all desperate. We're all desperate for solutions. We all know that we need to make some changes to make things a little bit better. Into this badly needed desire for reform, we have a number of options and many paths in front of us, right? We can undertake constructive and positive solutions, things like primary care reform, investing in long-term care and home care, dental care, pharmacare. In fact, all of these subjects and more, they've actually been topics that we've covered in the Canadian Doctors for Medicare Better Medicare webinar series. And if folks want to dive in deeper into those, please do check those out. But of course, even though we have these constructive and positive avenues for change in front of us, there are other people who are taking advantage of this moment to push for changes that the evidence shows, both in Canada and in other countries, they will do harm. They will do harm for the patients we look after, for our communities, our neighbors, our family members, and the system as a whole. And that's the subject of tonight's webinar. We are going to break down privatization into its component parts, and we're going to do it in three ways. So number one, we're going to talk about financing, right? In other words, who pays for or finances services. In Canada, it's been a relatively stable 70-30 split. In other words, 70% of all healthcare dollars are spent publicly and 30% are spent privately. And I think what surprises many folks, when we broach this topic, is how that compares to other countries. In the UK, Germany, Sweden, France, New Zealand, these countries we often compare ourselves to, they spend more publicly than we do, anywhere from 77% to 84%. So not a little bit more, in some cases, a whole lot more publicly than we do. The relatively low portion of public spending that we do is on services that are covered by Medicare, right? Doctors and hospitals. So when we hear this, this siren song of private financing, I think it's important for us to ask what would the consequences be if we eroded services covered by Medicare through more private financing, whether it's out-of-pocket payments or if private insurance companies got into the game. That's number one, financing. Number two, on what basis are our services delivered? Now, as folks know, even when a healthcare service is funded publicly, it can be delivered on a for-profit or not-for-profit basis. And I think many people are increasingly recognizing that privatization of delivery is understood as for-profit delivery, and specifically the entrance of investor-owned corporations, sometimes even private equity firms. And then the third thing we'll be doing tonight is talking not only about what the evidence shows, right, on the consequences of these forms of privatization, but what does legislation in Canada actually say on what is permitted and what is not? And it's important for us to understand this so we know, as people who are interested in fighting for the public interest, where we can apply pressure for positive change. And we're going to do this, as Katie said, with the help of our colleagues, Karen Palmer and Hasan Sheikh. And then we're going to move into a general discussion and finally an audience Q&A. So it is my pleasure to introduce Karen. Karen Palmer is a healthcare policy analyst and a health systems researcher. Her passion is anchored in equitable access to high quality care, where she works out of Simon Fraser's Faculty of Health Sciences as an adjunct professor. Now, Karen, to kick us off, what are some examples of where patients are currently paying out of pocket for healthcare in Canada, and what are some of the trends that we're seeing?
Thanks, Dan, and hello to everybody who's joining us today. I'm glad that you're all here. So we're here to talk about a word that I never use, actually, and that's the word privatization. So I think that the indiscriminate use of that word has led to the conflation of private pay and private delivery to the point where some people are arguing about apples and oranges, and it's really not very helpful. So this added confusion, I think, is especially frustrating at a time when we are all trying to figure out how best to improve timely access to high quality care. So I'm going to start with private pay for healthcare and what that looks like in Canada. So the Canada Health Act makes clear that private pay is unlawful for insured services delivered by enrolled physicians to enrolled beneficiaries. So in other words, it's unlawful for enrolled physicians to charge insured patients for services covered by their provincial or territorial plan. And as many of you may know, this was the heart of the Canby trial, in which the plaintiffs wanted physicians to be allowed to bill patients out of pocket or through private duplicative insurance, meaning insurance that duplicates what's covered under the public plans, for services that are otherwise covered by those plans. So there are other services that are not covered under the provincial or territorial plans, and these can be paid for privately, whether out of pocket or whether through supplemental insurance. So not duplicative, but supplemental, like the employer benefit plans that many people have. And some examples of that are dental care and mental health care when it's provided by counselors or psychologists, or rehabilitative care like physio or massage, or naturopathy or cosmetic surgery, or whole body scans, or prescription drugs, or eyeglasses and hearing aids, and home care, and physical exams for driver's licenses, and completions of various forms and sick notes, and much more. But that said, some of those services are publicly funded for certain populations through various targeted programs, but by and large, they fall outside of what's covered under our provincial and territorial single payer plans. So many would argue, I would be among them, that some of these services are gaps in Medicare, and that more services like dental care and pharmacare and home care to help older adults age in place, and rehabilitative care should all be publicly funded, whether through Medicare, whether through the provincial plans, or through some other funding streams. But there are examples of services for which patients are currently paying privately, but which ought to be publicly funded according to the spirit of the Canada Health Act. In some cases, Health Canada is now actually cracking down to close what are perceived to be loopholes. But in other cases, we really do need more advocacy and follow-up to Health Canada and to the provincial and territorial plan administrators. So let me give you some examples of those. Some virtual care providers are billing patients for virtual care visits that occur outside of certain hours. And they're claiming that during those hours, physicians in other provinces who do not have a billing number in the same province as where the patient is a beneficiary are, in their opinion, permitted to charge patients privately. Yet there is a reciprocal billing agreement to which all provinces and territories, except Quebec, have agreed. And it essentially says that if I live in British Columbia and I break my leg skiing in Alberta, my care in Alberta will be covered under this agreement. So many of us are asking why that agreement isn't being applied to virtual care. So similarly, some surgical and diagnostic facilities are allowing patients to travel out of province for faster access to pay privately for elective procedures, which, again, many believe violates the spirit of the Canada Health Act, which is all about care based on need and not ability to pay. In another example, nurse practitioners in some provinces are billing patients for care, claiming that because the Canada Health Act refers only to hospitals and physicians, they believe, exempt from the provisions of the Act, and they are, in their opinion, free to bill patients out of pocket. Another example is that some primary care clinics are effectively putting access to family doctors behind a paywall. So they're charging annual fees for access to the practice. And you may have read about this in the news this week. TELUS Health's Life Plus program charges patients an annual fee of $4,650 for what it calls preventative health care and wellness. And while the company claims that the fees are only charged for insured services, in an investigation over the last year, a would-be patient, Mark Winston, who's actually a colleague of mine at SFU, was told he would have to pay that fee to see a family doctor, and in fact, to see his own family doctor who had decided to work for TELUS Health. And so British Columbia's Medical Services Commission filed an injunction against TELUS Health for that program, claiming that it violates BC's Medicare Protection Act. And yesterday, TELUS and the Medical Services Commission settled that dispute. And TELUS is now in compliance with BC's Medicare Protection Act because they agreed in what they described as a highly collaborative, transparent, and thoughtful process to modify the program to ensure a clearer delineation between insured and uninsured services. I spoke about this last night on CBC, and I can paste a link to that interview later. So TELUS Health is not alone, though. Other investor-owned corporations like Harrison Healthcare, against whom British Columbia's Medical Services Commission also applied for an injunction, and some physician practices are either charging patients outright for insured services, or they are commingling insured and non-insured services, and sometimes crossing the line, which is very confusing to patients. So we have to be vigilant, and patients have to continue to report these instances to the Medical Services Commission, so that, at least in British Columbia, so that they can investigate. But this is going on across the country. So these are all examples that many of us want Health Canada to clarify and to enforce the Canada Health Act. And Minister Duclos says that he's doing that, including in his March 9th, 2023 letter, in which he wrote, "It is my intention to clarify in a separate Canada Health Act interpretation letter that no matter where in the country Canadians live or how they receive medically necessary care, they must be able to access these services without having to pay out of pocket." But private pay is just one aspect of the word privatization. So the other aspect is private delivery of care. And on this, the Canada Health Act is actually silent. It takes no position against care delivered in private facilities, whether those are private physician practices or whether they are private for-profit investor-owned facilities or corporations for that matter. Of course, there are other problems that come with investor ownership, and a core question is whether we want to use public dollars to pay the shareholders who own these facilities or corporations, and what consequences arise if we do that. And Dan and Hasan will talk much more about that as we go on. So my point is this: when anyone asks me about privatization, whether it's a reporter or on social media or in casual conversation, I stop the conversation before it begins, and I ask whether we're talking about private pay or private delivery. They are not the same thing, and they come with different rules and different evidence from around the world. So we ought to try hard not to contribute to the confusion by conflating these two distinct issues. And hopefully by the end of this webinar, that will become clear to you. Thanks for your time.
Thank you, Karen. And that's a perfect segue over to Hasan. So Dr. Hasan Sheikh is an emergency and addiction medicine physician in Toronto and an assistant professor at the University of Toronto in the Department of Family and Community Medicine. He's a board member at Canadian Doctors for Medicare and is actually one of the co-authors of our primer on the myths of privatization in healthcare. So Hasan, can you speak a bit more to what Karen was starting to allude to at the end of her comments about investor-owned delivery and concerns that we might have about the profit motive and how that could impact things like quality, patient outcomes, and our system more broadly?
Yes, absolutely. And thank you, Danyaal, and thank you, Karen, for breaking down the legal landscape around private pay. And as you mentioned, the other way this comes up in terms of privatization is about how care is delivered, even if that care is funded publicly. And so there's a few different ways that care can be delivered. It can be delivered publicly, for example, places like community health centers, public health clinics, or many hospitals in the country, especially outside of Ontario. It can be delivered on a private, not-for-profit basis. An example of that would be many hospitals in Ontario. It can be delivered on a private, for-profit, small business basis. So think of your family physician when you go, where that profit is really your family physician making a living and bringing home, the money that is made in running that clinic. And then there's really this big concerning new trend of private for-profit investor-owned delivery. And that's where this entity delivers care, even if it's publicly funded, but the obligation is to deliver profits to shareholders. And examples of this would be things like high-volume walk-in clinics, some new private surgical clinics that keeps coming up in the news, some of the long-term care facilities. And that's what I really want to break down right now. And I think a good place to start is to consider, what is even the theoretical basis around the idea that private, for-profit, investor-owned delivery, where the underlying purpose is profits paid to shareholders, not care, why would that even be helpful? And, the idea for that really kind of comes from this belief that healthcare is like a market good, that it's like going to buy a smartphone. That if you have the highest quality product at the lowest cost, customers will come to you to get care. And that there's this idea that that profit motive can create efficiencies and we'll get better care at a lower cost. But we know that healthcare is not a market good. Getting care is not like buying a smartphone. Patients have a difficult time judging quality. They do not have the perfect information you need for something to be treated like a market good. That's why they go to see a healthcare provider and put their trust in them for an assessment and for treatment. Also, in the system that we have, where healthcare personnel are a finite good, a limiting resource, we don't have the abundance of options. It's not like the fact that you can decide to go without a smartphone, or you can get any number of smartphone options out there based on your preferences. When you need healthcare, you need it. And so these different delivery models aren't competing on quality to get patients, because patients are patients, they're not customers. Let's take the example of a surgical center, a for-profit investor-owned surgical center. So if you need a hip replacement and you're desperate, you're going to go and get that hip replacement with the next one that's available, whether it's an investor-owned private clinic or a public one. And so they're not really competing on quality. They're really, they have a captive audience and a captive customer base. And so the question is, what is the market pressure going to exert? And what it is it's going to find ways to lower costs. And those costs can often mean trying to find ways to cut corners. These forces might explain why, when we looked at mortality rates in long-term care homes in Ontario during the pandemic, they were 78% higher in for-profit investor-owned long-term care facilities than in nonprofit or public ones. It might also explain why 1 in 7 private for-profit investor-owned clinics failed to meet the provincial safety standards. We see this internationally as well. In the United States, a systematic review found that there were higher mortality rates in for-profit hospitals than for not-for-profit hospitals. And when we look at data from England, what we see is that as they have outsourced care more and more to for-profit facilities, that's correlated with increasing rates of treatable mortality conditions. A 2017 review looked at a number of healthcare systems in the OECD, and they found that when you look at amenable mortality, so deaths that could have been otherwise treated, there's a real correlation over time that as amenable mortality is decreased across the board, that decrease is not happening in the same way in for-profit investor-owned delivered systems as it is in publicly owned and delivered systems. So that profit motive, improving quality and reducing costs, is a myth. It doesn't happen. And the pressures are really not there for that to happen. Not only does the profit motive in this case have the potential to affect quality, but it also drains resources from the public or not-for-profit delivery systems. It pulls staff with the promises of higher wages and simpler cases. And it just doesn't really make the changes that we're looking for in our system. And so the question is, why does this keep coming up as a potential solution? And I think there's a couple of reasons. One is there's real pressure from the investors themselves to say, we have the solution, and they're a bit biased. But the other, I think, is that it lets us relinquish the responsibility of coordinating the system, of taking care of the system, from the government onto private corporations. And that means further fragmented care when we actually need to go in the opposite direction and take more responsibility for our system and how we coordinate it. Things like centralized referral lists that can help us, use our resources to their maximum efficiency, really require us to take ownership of coordinating the system as opposed to the idea of further fragmenting it. Ultimately, there's really no reason why we need investor-owned delivery models, because we can do all of that same care on a not-for-profit basis. For example, with these community surgical centers, we don't need to use public funds to line the pockets of shareholders. We can do that in a not-for-profit way where the patient care comes first rather than profits. And so, I'm happy to chat more about it. I think we're going to have a great discussion later on, but ultimately, we think we should be treating patients as patients and not customers.
Thank you, Hasan. So, Karen, Hasan, I think you've very nicely, set the groundwork and laid out how privatization manifests through private financing or investor-owned delivery. But of course, these are not issues that are being debated in classrooms or in textbooks or in CDM Better Medicare webinars. They're living and breathing debates, right? They're factoring into decisions that are happening right now, and that some people are arguing could lead to, generational changes in how we do healthcare. So, of course, this begs the question, how do these manifest today? Like, what are the issues right now that are intersecting with financing and delivery? And so I'm going to turn to financing first. And Karen, I'm going to ask you in a second about the Canby case in BC. So many folks will recall in 2020, the BC Supreme Court issued an 880-page ruling against the Canby Surgical Corporation, which is an investor-owned surgical center based in BC that was seeking to expand private pay for physician care. It was quite a trial. It went on for a very long time. There were 590 exhibits that were admitted into the record. There was 75 lay witnesses. There were 40 experts from around the world that testified in the trial. It was a very comprehensive ruling. The plaintiffs sought to overturn it in the BC Court of Appeal, who found against the plaintiffs. And just a couple of weeks ago, the Supreme Court of Canada dismissed their attempt at an appeal. So, Karen, I think, it's safe to say you are one of the national experts on this case. You were literally in court watching things go down. Obviously, it's a big deal. Can you tell us why it's a big deal?
Well, so I sat through that trial, 4 years of it. Every day I had a chair in there that practically had my name on it. And I did hear all of the evidence as it was adduced by the various witnesses. And what they were seeking was to overturn the prohibitions on extra billing and on private duplicative insurance, so insurance that duplicates what's already covered under the public plan, and on physician dual practice. So they wanted doctors to be able to work in both the publicly funded system and in the private pay system, providing the same services in both. And so we heard all sorts of evidence about what kinds of incentives that puts into a system and what kinds of pressures that puts physicians under when they're faced with the opportunity to earn more money privately through private pay than they are necessarily through public pay. We heard testimony from all around the world, witnesses from the United States, witnesses from Ireland, witnesses from New Zealand, witnesses from Australia, all describing the kinds of struggles that they are having when they have basically moved towards a multi-payer system where the public system funds part of the care and either private duplicative insurance or private pay funds other parts of the care. And they're kind of competing priorities and competing moral issues that arise when physicians are essentially placed in that kind of a conflict of interest, and the inequities that arise. And so, there are as Dan said, there are 880 pages, and I actually encourage you to read it. It is beautifully written in very plain English. I've read sections of it over again and over again, and it's not written in complicated legalese. Anybody can read it, and you can find it online. We can post a link to it. But the evidence was overwhelming. The Supreme Court of British Columbia was convinced. Justice Steeves was presiding over the trial. He was convinced of the evidence and ruled that the Medicare Protection Act, British Columbia's Medicare Protection Act, is constitutional, that it is not unconstitutional. The Court of Appeal came to a similar decision, and as Dan said, the Supreme Court of Canada declined to hear the case.
Thank you, Karen. It was years long, and I think it gave a sense of, it felt almost like gave a sense of finality. But of course, these issues never go away, right? We often call these health policy zombies. No matter how often we, go to court to defend publicly funded healthcare, these things always kind of rear their heads. So I think this is an important precedent that will serve us well for the next time we have to fight for Medicare in court, whether it's the legal courts or the court of public opinion. So let's pivot a bit over to financing, and I think to delivery, because
there it goes.
I know See, Karen is you still have some more teaching to do for me, I think. Because the thing with financing, we have these legal cases, we have the Canada Health Act, and we have, some kind of rules, some kind of framework to limit or minimize private financing for physician and hospital care. But there's not really any equivalent legislative framework for for-profit investor-owned care. And so I think many of us see that as the thin edge of the wedge, right? If privatization is going to happen in our provincial healthcare systems, it's going to start on the delivery end. And I think that's what we're seeing, right? Across many provinces, they're starting to contract out to for-profit surgical centers. We're seeing, as Karen, as you mentioned, TELUS get into the primary care game, introduce paywalls and that sort of thing. So Hasan, again, turning to delivery, could you speak a little bit about some of those trends, and why should we? You said a little bit about why we should be worried from a theoretical sense. You talked about market failure and asymmetry of information. What does that look like right now in some of the provinces that I mentioned?
Absolutely, Danyaal, and unfortunately, we haven't legislated against poor public policy yet in all cases, but hopefully we'll get there one day. Right now, I think a lot of this plays out in the debate around how we tackle this surgical backlog. And we were already struggling to, ensure that people got surgical care on a timeline that was appropriate. But COVID obviously has introduced further strain on the system and just significantly increased the wait times for surgeries that are, we call them elective surgeries. I think it's a terrible name because it makes it seem like it's not necessary surgeries or it's choice, but it just means acutely urgent surgeries.
Planned.
And yes, planned surgeries. Thank you, Karen. And so this is playing out in a number of places across the country. And I'll give you a few examples because they've been in the news recently. So in Ottawa, there's a group called the Academic Orthopedic Surgical Associates. And it's a for-profit group that has been renting operating rooms on the weekends from the Ottawa hospitals. So this is capacity that could exist in the public system, but is instead being contracted out to a for-profit investor-owned surgical group. And there was a recent story in the Ottawa Citizen about how that group is now able to pay double the wages for nursing care, and that has led to a concern that it is actually draining staffing resources from public operating rooms, and they've actually had to decrease the cancer surgery cases that they're doing. And so we can see how that drain of resources to the for-profit investor-owned delivery models can affect the public system, the publicly delivered system. Similarly, in Quebec, a recent report compared the costs of carpal tunnel surgery and colonoscopies done in private for-profit clinics compared to public ones. And the private clinics, the costs were significantly higher, in many cases more than double. And interestingly, when they look at the trends over time, what they found is in the public system, they're doing those surgeries for cheaper than they used to, while in the private system, it's actually getting more expensive. So this idea that the profit motive is going to help us find efficiencies and do things cheaper and higher quality is just not playing out in the data. It actually reinforces that the public system is the one that's innovative and actually finding efficiencies. And as I mentioned before, there's really no reason to go the investor-owned, for-profit route for this. There are ways that we can do this on a not-for-profit basis. So in Toronto, 2 hospitals, Sunnybrook and Michael Garron, have basically said, we have this OR capacity and we're not using on the weekends. Let's expand our resources to try and tackle some of the surgical backlog this way. And they've implemented a regional centralized referral wait list so that they can actually coordinate across the region instead of just tackling a wait list at one hospital. And so they're using our publicly funded, publicly delivered system to tackle the surgical backlog and use our resources to their maximum efficiency. So once again, there's no reason to do it on a for-profit investor-owned way where the bottom line is about lining the pockets of shareholders. Instead, we can focus on providing care that people need.
Thank you, Hasan. You know, there's also areas where I mentioned the thin edge of the wedge, where we see, private financing and of course investor-owned delivery overlap. And one of the examples that's been making a lot of news has been this concept of upselling. So, Hasan, why don't we continue with you, and then Karen, I want to get your take on upselling as well. But Hasan, since we're seeing this happen, I think most often in these private for-profit institutions, do you want to take a couple of minutes and speak to that?
A really important point. I think it talks about it, or it speaks to that idea of this being the thin edge of the wedge. And really what we're talking about with upselling is that even in this, privately delivered model, with public funding, patients aren't paying out of pocket. But there are certain things that may not be covered that might be, good choices for patients to make who can afford it. But when you're in that model, we just don't know. And so I'll give you an example. Say you're going for a cataract surgery and you talk to your surgeon and they say, you might really benefit from a specialized lens that unfortunately isn't covered by the public system, and you'll need to pay out of pocket. And, that decision, when you don't have perfect information, when you don't actually know whether or not you need that lens, really relies on you to have a deep, trusting relationship between the patient and the physician. And it really comes down to that trust. And if you have an investor-owned private facility where, again, the purpose is to make a profit, and if you have a system where that physician might get a kickback or might be incentivized in many different ways to sell a certain number of specialized lenses, that trust is eroded, and you don't know where that recommendation comes from. You may very well would benefit from a specialized lens, but you just don't know. And there are examples of not-for-profit facilities, for example, the Kensington Eye Institute in Toronto, which is an independent health facility, not-for-profit, connected to a hospital that provides really high quality, high throughput care, because they do certain things really well and do a lot of them. There's no financial incentive in that type of a facility for the physician to sell you a specialized lens. And so you can really have that discussion and trust that decision that you make in conjunction with your physician. And so it really is about making sure we find the right incentives so that quality of care, patient autonomy, patient choice, all of these things are maximized. And it's hard to do that when you have the profit motive kind of creeping its ugly head, and the people that are at the center of what we're trying to accomplish are the investors as opposed to the patients.
Karen, did you want to add to that?
I think Hasan has covered it pretty well. I mean, I think I'm not a physician, so that the sanctity of that doctor-patient relationship, you can speak to better than that. But I just think that when patients aren't certain whether the advice that they are receiving is motivated, what it's motivated by, it's confusing to patients.
The other thing I'll add to that too is, one of the ways that we can really drive health system improvement, of course, is data. And understanding, when things like upselling are happening, in what circumstances. But oftentimes when care is delivered on a for-profit basis, companies can, claim data like that is proprietary, or put up high fees for folks to access the data. So it's technically available in theory, but it's out of reach for many researchers who might be working in the public interest. So there's a really important data piece around transparency and monitoring outcomes that sometimes can be more difficult to do when you have that profit motive there as well. Okay, great. And the one other thing I will add too is, Hasan mentioned the example of these, community-based surgical centers like the Kensington Eye Institute. And in fact, I think we're seeing actually a positive trend of low complexity care that can be done on a specialized basis, but in higher volume in the community. But we're having a really hot debate right now about on what basis should that care be delivered. And that's where I think we're seeing a lot of these investor-owned surgical centers try and make the case that, they're the ones to do it. But we have so many examples of where hospitals are doing this on a not-for-profit basis. They're using their community-based surgical centers as a way to cycle staff to give, for example, nurses a break from some more intense care in ICUs or emergency departments. And a great example of that is I think there's someone posted a question about the Leafs. He's not a Leaf anymore, but Nazem Kadri used to be, and he's from London, Ontario. He gave this donation to London Health Sciences Center. And they opened this surgical center in his name, the Nazem Kadri Surgical Center, and they do outpatient orthopedic surgery, so things like hips and knees, as a hospital site in a very specialized and high volume way. And they have great outcomes in terms of low costs, high volume, and low rates of complication. So, these sorts of things are happening as extensions of our hospitals on a not-for-profit basis. And investors certainly, don't have a monopoly on these, and we shouldn't allow them to use these centers as an entry point, I think, into treating healthcare as a profit center. Okay, so that Karen and Hasan, thank you so much for rooting those concepts of privatization in terms of some contemporary debates. I'm going to hand it over to Katie, and Katie's going to moderate some of the audience Q&A so we can get into some of the burning questions that folks who are joining us tonight have.
Thank you so much to all of you for the insights so far. And thank you to everyone who's participating in both the chat and the Q&A. I suspect we will not get to all of these questions, but there is so much we're going to want to dive into after as well. I'm just going to start with a question that was actually sent in advance so that I can also read through all the questions in the Q&A box right now. The one that was sent from a member was a commentary that most, and then in brackets they said maybe all European health systems have parallel public and private systems to some extent. And in their question, they argued better health outcomes at lower cost. And so the question is, what can we learn from international health systems, especially those in Europe? Is what's to be gained by making those international comparisons?
I think, this is the European examples, I think, are really interesting ones, because many folks who are trying to introduce parallel system for financing to Canada often point to Europe. Europe's a big place, right? The EU is 20 something different health systems, and there are some things that they do have in common. So I mentioned in my opening remarks that most of the European countries that we compare ourselves to, they actually spend more publicly than we do. They also have higher taxes than we do. They have higher social spending. They do a better job of addressing the social terms of health, and physicians are typically paid less. So now I don't think this is the spirit in which we receive the question, but when we often get into these conversations in public with people who are raising this issue as a way to undermine public health care in Canada, you will rarely see someone advocating for private financing who's also advocating for higher taxes, more social spending, and lower physician pay. So I think that's an important contextual piece of information to have when we talk about European health systems. That being said, there actually are a lot of really good things we can and we should learn from health systems across the world, including Europe's. For example, the Dutch do an incredible job with elderly care and looking after seniors. They've pioneered this model where they're not institutionalizing older adults. They're putting them in, familiar home-based settings. They have better staff to patient ratios. And I think, really looking at the way we can be innovative with delivery and learning from folks around the world, including many European jurisdictions, is where it's really important for us to take some lessons.
You have to look at what, when people talk about Europe and the fact that they say private insurance and private pay, you have to look at the history of each of the countries that they're talking about. So I'll just give two examples. So in Germany, the German healthcare system, which arose, in the 1800s through workers' guilds. So hundreds of workers' guild, every guild had some sort of health plan. And so their challenge has been to merge those into a sort of a national health system. But there are remnants of those individual insurance plans that still exist in Europe. We didn't have that, in a sense, disadvantage in Canada. We were able to start sort of fresh with a new system that wasn't trying to amalgamate a whole bunch of workers' guilds with separate payment systems into one. So that's, an example from Germany of why they still have this remnant of a multi-payer system. And then in France too. So France introduced copays. And so we, of course, don't have those here because they're against the law for insured services that are covered under the Canada Health Act. But so then what they did, when you hear, well, France has private insurance, well, what they did was they introduced private copay insurance. So you can buy insurance in France to cover the cost of the copayments. And, the same thing in Australia. So all around the world, different healthcare systems arose with different histories and in different political cultures and in different social cultures and in different contexts. And so, these kinds of comparisons cannot be made directly anywhere. So each country has to consider its own history and culture and politics and social values and context when making these kinds of decisions.
I think it's also important to recognize the giant next door, and we often use the U.S. as a warning sign, but I bring it up when we're talking about Europe because if we were to introduce private insurance, for example, for physician or hospital care, we're not going to get a friendly French or Dutch or German workers' guild coming into Canada. There's too many linguistic and cultural barriers. We're going to get the big American insurance companies coming in and setting up shop here. In fact, we're seeing that in the NHS in England because there are similar linguistic issues. Of course, they're both English and Anglo countries. And that's, I think, what we would have. So if we want European style two-tier healthcare, that may be what we want, but we're not going to get Europeans insuring us. We're going to get large American insurance companies.
I'm going to ask a bit of a two-parter because we got two great questions from Alexander Natoros. One, I feel like we've touched upon it in a few places, but the question came early, and it's a great one, asking about the panel's perspective on nonprofit cooperative models for healthcare delivery, with examples potentially in primary care and also the potential for multidisciplinary surgical care, with an example where they are located in Port Hardy. And then a follow-up question is, how do we start to tackle reducing bureaucracy within the public system? Are there ways to make the publicly delivered facilities more efficient?
Hasan, why don't you talk about not-for-profit community health centers and other not-for-profit cooperative models?
I was just about to jump in, but it's always, you never know who's going to unmute and speak first. So we touched on this a little bit, that these not-for-profit facilities are really excellent ways for us to look at how we structure our system, and they can really be quite exciting innovations. As we talked about, and Danyaal brought up about independent health facilities that are connected to hospitals, for instance. It has so many benefits in terms of getting care out of the hospital and offloading some of the pressures there, as well as being able to create efficiencies, which was another part of the question, by doing simple surgeries really effectively and high volumes. But also it helps us still remain connected as a system, right? Instead of a kind of a for-profit delivery system that's off on its own, you can ensure that the physicians working in, nurses working in that system are working in both. And so they don't lose skills by only doing simple cases. And they can also learn by doing these high volume cases and see what kind of efficiencies they can learn and bring back to the public hospital. And so it doesn't erode our capacity to provide on-call services, because in many public hospitals, you need to provide on-call services if you're staff there. But if you leave completely and go to a for-profit surgical center, then you no longer have that obligation. And then in terms of the question around how can we create efficiencies in the public system, I would say, first of all, again, it depends on what we're comparing to, but we know that especially private multi-payer private pay systems are much less efficient, because you have so many administrative costs associated with figuring out who's insured for what and who's the first payer and who's the second payer if the first payer doesn't decide to pay, and how do you go back and forth. And it actually ends up costing a lot of resources. And we have some of the lowest administrative costs in amongst our peers in terms of how efficient our system is. But I really think a big piece about efficiency comes in coordinating the system. And I think that's where we do a really poor job right now, which is we fund the care and we deliver it often on a private, not-for-profit basis, or a small business private basis. But we don't take responsibility for coordinating that care and figuring out where do we need to match the needs and the resources. How do we make sure we've coordinated care so we're using resources most efficiently? So things like, for example, centralized referral for surgeries in a region. And there's so many examples like that where we can provide better coordinated care with a reduced administrative burden by doing this in a single payer system that actually takes ownership of how care is delivered.
I'm just seeing such sophistication in the questions from the audience. Like, this is a very well-informed group listening to us today. We should have some of them speaking instead of us.
Absolutely. I think we'll need to follow up with a few of these question askers. I have a question from Malcolm, sort of responding to the public statements from Minister Duclos around concerns around the emergence of out-of-pocket fees. So a great and timely question is, how do we ensure the Canada Health Act is enforced? And what does the government or what does the public need to do to push for enforcement of the Act?
I will just say that I am encouraged by what I have been seeing recently coming out of the federal government and their efforts to enforce the Canada Health Act. Canadian Doctors for Medicare has written to Health Canada and has described some of the concerns that we've seen. We've sent them evidence, and they have responded. I think that if you write to the Canada Health branch of Health Canada, they respond, and they are very receptive to receiving information from organizations like Canadian Doctors for Medicare. And I do think that Minister Duclos, and at least this ministry, is quite committed to enforcing the Canada Health Act. Katie, I'm looking for the article about Quebec that recently came out about the extra billing, not the extra billing, but the withholding from the transfer payments. And the huge amount of money that's being withheld by Health Canada from the transfer payments to the various provinces that are extra billing. So they are acting. I wouldn't say they always have, that's for sure, but I certainly see great hope, at least right now.
We also have a great question about where P3 hospital projects fit into this whole discussion, with examples of how new hospitals are being built in Ontario.
Yeah, I think that's a good question, because what we've really been talking about is on the financing piece is the actual payment for the services that are being delivered, and similarly for the delivery about the services themselves. We haven't really talked about some of the capital projects, which is what P3s are about. At CDM, we haven't specifically delved into this issue, but many of the folks that we work with have, and I think have appropriately raised some of the concerning issues around cost overruns and how sometimes P3s can often cost the public more. than traditionally financed capital projects. There are alternatives to P3s to finance capital expansion. So, for example, many hospitals will sometimes issue, bonds as a way to borrow money to build a new wing or to upgrade certain infrastructure, and that uses some kind of market mechanisms, but it's certainly not about introducing, a brand new a standalone private investor and guaranteeing profits in terms of capital expenditures. So it's a hot issue. It's one, as an organization, I'll say we don't have a ton of expertise on, but of course we can't ignore when we talk about this issue.
The P3 story in the National Health Service has been unfolding for more than a decade, where in the National Health Service, much of the facility ownership was government. Government owned those facilities. And so their big shift hasn't been so much on the private pay side, but has been on the shift in ownership. I mean, Richard Branson, Virgin Air, owns Virgin Care. So, there's a whole bunch of that happening in the NHS, and there's an abundance of literature. People like Alison Pollock has been writing about this for 20 years. So, her work is stellar on this. And I think that this is a place that we should be also being, paying close attention to what has happened in the NHS, and therefore what are we seeing here and what lessons?
I talked about this in my opening remarks about how, when we look at the data from the NHS, how the contracting out to for-profit facilities has led to an increase in amenable mortality. And so there are real concerns about that quality. And I will just say, these investor-owned groups are not investing in these systems out of altruism. They are doing this to extract a profit. And ultimately, those profits come from public funds. These are things that we could otherwise pay for publicly. And it really is about shifting around. Do we pay now? Do we pay later? But we're paying more because ultimately we have to pay a profit margin as well. And so I think one of the things we need to decide as a society is, what system do we want? And do we want a system that takes care of everyone and upholds those principles of Medicare that we hold so dear? And what are we willing to pay for? And are we willing to take care of the system that we want and the system that we think everyone deserves? Because ultimately we're paying for it and paying more in the long run if we don't really safeguard this and take care of it up front.
We had a follow-up question asking if there's any evidence that private, not-for-profit surgical clinics are better suited than those procedures happening in surgery. I think that's coming from a place of concern that hospitals have been eroded and defunded over time, and that moving some of these procedures outside will just result in sort of further defunding of hospitals.
Yeah, I think it's a great question, and I can certainly see the concern there, right? Is that our hospitals are already struggling. It's a stressful situation. There's complex cases. There's cuts to funding. And then you're going to take out kind of the simple cases and the ones that kind of give everyone a break to catch up, and move them to an outpatient or an independent health facility. I think that's where that difference between the not-for-profit care integrated into the system and a for-profit investor-owned care, not integrated into the system, is such a big divide. Because if you take out those cases from the public system and you put them into a for-profit investor-owned system, what you're going to get is it's going to look like they have great outcomes and low costs because all of the cases are simple and easy. And meanwhile, the public hospitals are going to get defunded further, and it's going to be even more strain, and people are going to burn out more, and you're going to see this exodus to the investor-owned facilities. But when it's done in a way that's integrated with a not-for-profit independent health facility that just helps us offload the hospitals and say staff work in both, and you have your nice simple day where you do the same thing over and over again, and then you have your 2 or 3 days that you're in the public hospital taking care of really complex sick patients, it actually accomplishes those same goals, but it just does it in using our resources most efficiently, where we can do those high volume, tackle the surgical backlogs, and do that in a way that really improves care and gets better outcomes at lower costs, and really coordinates the system properly.
Just to build on Hasan's answer, the example I shared in London, that's actually a hospital, doing this through a hospital clinic, right? This LHSC Nazim Kadri clinic. It's a hospital building right across the street from their main hospital site. It's hospital staff, it's hospital workers, it's the same hospital infection control policies. So really, it's just an extension of the hospital, and if you do it that way, it also, as Hasan talked about, for not-for-profit centers, it allows a tighter integration of care and even referrals. For example, if we have a brand new, investor-owned surgical clinic that's starting up with its totally independent infrastructure, I'm still making referrals to, my orthopedic surgeons at my local hospital. I don't know that this clinic, putting aside all the issues with investor ownership, I don't know that this new clinic has popped up and is around. It's not, integrated with the referral pathways that are already out there. Whereas if we build these as extensions of hospitals, which many folks are advocating for, then it's just a natural extension. The other thing I would add too is, if we use our hospitals to build these, is I think Pat Armstrong, I saw her as one of the attendees, and she's Pat, it's nice to see you here. Pat is a brilliant researcher on long-term care and other issues, and she has this, I'm going to paraphrase Pat, and you'll have to apologize to me. She has this beautiful saying that the quality of the work is quality of care. And when we have people working in hospitals with workplace protections, with benefits, who are also the same folks with these same sorts of workplace protections that are working in these hospital sites that are doing high volume surgeries that are lower complexity, and get people in and out faster, then we can also maintain the quality of work for people who are working in the system.
We had two separate questions, but kind of getting to the same point, which is sort of like, who's behind the pro-private lobby? But perhaps more actively, are they actively steering professional bodies, so medical associations or other bodies, towards lobbying for either increased privatization? So either way, either for private pay or for the contracting out and delivery. And any comments anyone would have on that? And I will say this is probably our last question for the night.
It's a tough, it's a loaded question, right? Like who is behind it? Well, I think, the way markets work is, if there's a profit to be made, then corporations whose job it is to make profits will look for opportunities to do so, and then will do what they need to do to set up a business to make that happen. And I think, virtual care has been a really interesting example, where we had, because of the pandemic, we had really positive changes to make virtual care just a regular part of our system. But because it happened so quickly, there were lots of opportunities to, I think, take advantage of it in inappropriate ways. And we've seen the rise of investor-owned kind of walk-in style virtual care clinics that aren't integrated in the system. We had, Babylon Healthcare in Alberta, which was owned by TELUS. We're seeing Shoppers Drug Mart and Loblaws kind of get into that game as well. And these are big companies who are seeing it as a market opportunity, and getting into battles with governments who are, I think, standing up to them in places like BC, but also have allies in places like Alberta. And I would certainly put some of those big companies who see opportunities for dividends and executive bonuses as some of the folks who are pushing this agenda.
Yeah, I think these are values-driven events. I mean, people have different values around whether healthcare is a right, whether healthcare should be available based on need and not ability to pay. I mean, I'm normally live in British Columbia, but I'm in my mother's house in Alberta. I'm in Calgary, So I'm surrounded by the election that's coming up here and the debates that are going on about healthcare here. And, the acting premier, Danyaal Smith, who recently said that she wondered whether everybody should just have a medical savings account and catastrophic insurance instead of Medicare. So, these discussions are going on and people are driven by different values.
I will just say one other to build on that and to build on what Danyaal said about, it's when these opportunities arise and when there's a way to make profits. And I think part of this comes from the fact that there is a pressure that comes from the fact that the public system, the way it is structured right now, leaves too many people falling through the cracks. And that's where, some of the things that Danyaal alluded to at the beginning of the webinar, talking about public solutions, talking about ways that we can improve our system and better coordinate it, and the evidence base that is out there for how we do that, is really the first step we need to take, because that will actually reduce the calls and the pressures for these kind of zombie solutions of privatization. And I think it really, the responsibility lands on all of us to look at how do we bolster the public system so that it works for people and make sure it doesn't leave people behind, so that this topic, so that we never have to have this webinar again. Let's put it that way.
Good luck. Good luck.
The best defense is a good offense.
I feel like that is an excellent point to transition to thanking everyone for joining us this evening. Thanks for joining us. We hope we never have to host this again. No, I'm just kidding. Thank you so much for joining us, everyone, tonight, and for the incredibly engaging chat and Q&A. I am sure all of us are going to be looking through and wanting to follow up with many of you. If we didn't answer your question live on the webinar, we will follow up. And Danyaal, Karen, Hasan, thank you so much for participating, not just tonight, but for everything you do every day to help us all better understand these complex issues and to make the system work better for all of us. I must say, if you're a medical student, resident, or physician on the line and not yet a member of CDM, please consider joining today so you can stay engaged in our work. And for everyone else, thank you for joining us this evening, and we look forward to working with all of you. The work ahead is great, but so are all of you. So thanks again for joining us, and we'll see you next time.